I want to welcome everyone to our MCH essay seminar tonight, the Maternal and Child Health Student Association at UAB. Tonight, we are focusing on some maternal and child health related research that is going on or has been going on around the globe. And I want to admit our new person and introduce our speakers real quick and then throw it to them because we've got a panel of three and we've given them a compressed amount of time to share their research. And then we've got a Q&A session at the end for questions not only about their research, but about their um, educational journeys. And so our three speakers are Aduke Tuluhi. Um, and she is with she's a postdoctoral research fellow with the UAB School of Medicine and the Department of Obstetrics and Gynecology. We've also got Joycelina Imafadan. Oh, I came close, I think. She'll correct me when she gets on. She's a graduate research assistant in the UAB School of Public Health and the Department of Health Policy and Organization. And then Anastasia Smith is a clinical research manager with the UAB Division of Pediatric Neurosurgery. And so, without further ado, I'm going to throw it to, and I can't remember if we talked about an order.
Yes,
Who was going to go first?
I'm first.
All right, I'm going to take the spotlight off of all of us but Joycelina and kick it to Joycelina.
Great. Thank you so much, Julie. And hello, everyone. Good evening. Really excited to be here. I'm also a member of MCHSA. I don't come as much only because I'm in the process of getting my dissertation completed, but I'm really excited to be sharing today my progress so far and some of the results with you. All right, so for my doctoral study, my research is focusing on perinatal depression and perceptions of perinatal mental health and services among Black foreign-born women in the United States. So for today's talk, I'm going to give a quick introduction about like the topic, the background, public health significance, and then provide an overview of the three papers that I'm currently working on, which are all interconnected, and then talk a little bit more about the implications for practice and policy. But before diving in, of course, I want to just like back up and give a little spiel about terminology that I'm going to be using. So you're going to hear me a lot say perinatal mental health. Sometimes you might hear maternal mental health. And I do want to put a disclaimer that I do understand in public health research, we are moving towards gender inclusive language, but you will hear maternal mental health. And I like to think about these terms as like a big, broad umbrella, kind of like it encompasses a lot of emotional, mental health, the good and the bad, one's well-being. Then underneath that would be kind of the perinatal mood and anxiety disorder. That's one part of it. A lot of my research looks at perinatal depression. So that's a specific condition of feelings of sadness, depression, and some definitions do include anxiety during that perinatal period. So perinatal does mean during pregnancy and postpartum period, which can be up to a year. I am looking at both periods, depression during pregnancy and postpartum. So also, how did I even get into this topic? So my background is in public health, community health science. I do have a bachelor's in psychology. And when I started this program back in 2021, I had no idea what I was going to research, but I was really interested in maternal health and child health. Something that stuck out to me a lot in a lot of these conversations and conferences I was going to was maternal mortality. And when I was doing a lot of my reading, I saw that there was a lot of discussion around mental health, maternal mental health as being like one of the leading and preventable causes of death for postpartum women. And I just got more intrigued in that, like reading through like the Alabama maternal mortality review report, and also seeing that in June 2022, so summer of 2022, there was a national blueprint that came out about maternal health. And it did talk about mental health, but not It did talk about mental health, maternal mental health, but didn't really have much information, but had good recommendations of what states and local health departments can be doing. But there wasn't much talk about Black immigrants or immigrants, just like a little bit of a mention about disparities. So that's where like my initial interest came from. So moving on to the significance of like why this is important, and there's four things that I want to highlight. The first, as you see here, is the commonality. You'll see a lot of reports are doing some research on the prevalence of depression, of anxiety, of poor maternal mental health, poor perinatal mental health. CDC estimates that 1 in 10 women in the US who are pregnant, postpartum, will experience symptoms of depression. It's very common, but these numbers do fluctuate. It can be higher depending on different social demographic characteristics. So, what I mean is like your income level, race, ethnicity, education, where you live. So, all of those can play a role. And there's also a lot of reports suggesting that immigrant women in the US, they might have a higher prevalence of postpartum depression or depression, symptoms of depression during pregnancy. It's also a really vulnerable period for those who are pregnant because your body is going through a lot of biological, psychosocial, and emotional demands and changes. And as I was talking in the previous slide about that connection between maternal mortality and mental health, we also find that there's elevated risk of comorbidity. So what that means is that if you are experiencing poor mental health, you do have elevated risk of other complications, including pregnancy, childbirth, and other health issues that can arise. And last but not least, there's a lot of societal economic consequences too. So when you're thinking about having poor mental health and how that affects your well-being, your ability to function and do your regular routines, and even your productivity and work, that comes with a consequence on the healthcare system if it's untreated or not diagnosed. And then what you see below is it is from a few years ago, 2019, but the main point is just to show that this is really costly again for the US healthcare system. So my population of interest is African immigrants in the US, and some of the work that I'm doing, I also look at Black immigrants overall. And my interest in this population is that even though it may be like a small population, only 5% of the foreign-born population here, it is a fast-growing immigrant community in the US. And we also find that African immigrants in the US, contribute significantly to the US economy and the workforce. So we see that there's a lot of reports on they contribute a lot in healthcare and transportation. They help alleviate some of the workforce shortages, and they have significant economic contribution in their spending power and the taxes. So as I was doing this research, and I started in like 2023 first with like just reviewing what was out there, I came across a really great resource called the Policy Center for Maternal Mental Health. And they do this state report card for the US where they look at three things. They look at the available providers and programs, they look at the insurance coverage and treatment payment. They also look at screening and screening reimbursements all around maternal mental health. And back in 2023, I saw like the country had an average score of a D. So we didn't fail exactly. I mean, depending on what state you're talking about, right? But we weren't doing well. Last year it did improve a little bit by D plus, and this year we are at a C minus. So what does this mean as you're looking at this map? There's a lot of inequities going on, there's a lot of disparities, and there's a lot more work that we have to do. So that's what led me to really go and investigate into this topic. So now I want to get into the papers. I'm going to first start with the scoping review. And in my case, the scoping review was really helpful because this really set the foundation for where I was going to go with this literature and this study. So there's different things that you can do with a literature review. The type that I did was a scoping review, and this was really because I just wanted to explore the literature out there, get a little more familiar with the topic, see what's being discussed, specifically as it relates to maternal mental health for the perceptions, the experience, and the outcomes of Black African immigrant women in the US. So I started this scoping review back in fall 2023, and I used some guiding frameworks to help think about my question, think about my terms, think about the process of how I was going to eliminate my eligibility criteria. So based on those three things that I previously showed, the experience, the perceptions, the outcomes, those helped me to think through of my key terms. I worked with a public health librarian here at UAB to kind of craft those terms and used a bunch of information sources and EndNote as my task citation manager. And through this process of going through titles, going through abstracts, going through like keywords and reading through the abstracts and the elimination, I came to 29 records for my results. So you might be thinking 29 is a great number, and I think so too. But when I dive in and get into like these descriptions, you'll see that there was actually a lot of limited results pertaining to what exactly I was trying to understand, and that was maternal mental health of African immigrants in the US. So I actually had to expand a lot of my research to kind of look at other higher income countries like Australia, Canada, some comparable places, the UK, of what was going on with maternal mental health of Black immigrants there. And then I realized also from that that this is an understudied population, right, in the US. There's little attention there, and the research that was there, as you look down and you look at category, I only had four that was about, sorry, two that was about maternal mental health. So that yellow circle should be on the two in the US. Even though a lot of it, as you see on the top right, was in the United States, a lot of it talked about reproductive health outcome, refugee health, more of the PTSD, but not necessarily mental health during pregnancy or the postpartum period. So from the scoping review, here are the main things that came out of it. So there were five, as you see on the left-hand side. Just in the interest of time, I won't have all the time to go through these in details, but happy to talk about it at a later time. But the main thing I do want to say about these themes, so the first one being the healthy immigrant effect, which I'm going to talk about in the next slide, perceptions of maternal mental health experience, maternal depression outcomes, and specifically looking at postpartum depression and anxiety, and then the utilization of mental health services. The big takeaway and what I want to say about this is that these things help me to inform my papers for paper two, the quantitative and qualitative. So, with the healthy immigrant effect, and the reason I want to talk about this in case it's a new term to use, because this really sets the stage for my next two papers. And this is a term that refers to this phenomenon. It's kind of a paradox, thinking and assuming that immigrants that come to a host country, they tend to have a healthier outcome than the native borns. So, this would mean in this assumption, when we're talking about maternal mental health, that immigrant Black women who are in the US would show better mental health outcomes than their counterparts. So, looking specifically back again at Black US born women. So, even though I didn't necessarily find this in the scoping review, I found a lot of things around reproductive health of Black immigrant women, comparing them to US Black, that showed that Black immigrant women did have favorable maternal and reproductive health outcomes. So this is things like fewer preterm births or longer gestational periods compared to Black US born women. So I was really interested with my next paper to kind of understand what are the outcomes of perinatal depression for Black foreign women that are in the US, and how does this compare to the native born Black women in the US? So, this is where paper two, quantitative, comes from. And again, the motivation, which I talked about, that limited results on perinatal mental health research of this population in the US, and barely any literature around like what's going on with the outcomes of perinatal depression for African immigrants. I also found that when I was doing a lot of research around the healthy immigrant effect for Black immigrants, there were a little bit of mixed results. Some saying that Black women, Black immigrant women, or immigrant women in general have higher or they have worse maternal mental health outcomes, and some saying that they didn't. So I also wanted to investigate this in the context of the US. So for my quantitative study, the data set that I used was CDC PRAM. So this is a publicly available data set. It's a really great data set if you all are interested in looking at maternal health outcomes. It has a lot of things around like behavior, mental health, demographics. And what I did is I used the phase eight, the 2016 and 2022. And I selected this because in 2020, they started to collect nativity as one of the demographics through the birth certificate variable. So I can now look and compare foreign born woman, Black woman, or of any race with the native born. So for my methods and specifically about my variables, my outcome was looking at perinatal depression. So I looked at this independently at two parts. So during pregnancy and then postpartum period. And then for my predictor variables, I looked at a wide range of social demographic, health, and behavior indicators using a framework and also just using what was available to me in the PRAMS data set. And after adjusting for missings and going through the data, I was left with a total sample of 9,322 Black women. So this was inclusive of foreign born and native born. But specifically for Black immigrant women, I had a sample of 1,597. And here are some of the demographics on average of how that sample looked like. So now moving on to my findings, I'm going to go really fast on this one. What I found was that when it came to Black foreign-born women, they had lower rates of depression during pregnancy and postpartum compared to Black women. And when I looked at nativity specifically to see if that played a role, I saw that during pregnancy, Black foreign women were 66% less likely to report symptoms of depression compared to Black women born in the US. So that was the only period that was significant. I also looked at the predictor variables that were significant with depression during pregnancy and postpartum. So with pregnancy, I found that income and health insurer were the only significant ones. And when it came to postpartum period, only age and region. And now moving on to the qualitative study. This one is still in progress, but this was again motivated by the scoping review and seeing some things around perceptions and experience and utilization of mental health services and wanting to really understand what does this look like in the US for this population. And also not just exploring, but also hearing from the women themselves about strategies and recommendations that they would have for us who are doing research, who are doing practice and policy to better support their mental health during pregnancy and postpartum. So this is the flyer now. Maybe a lot of you all had saw it. And with my eligibility criteria, I was looking at women 18 plus who identified as African that had a child up to 2 years postpartum. And we did one-on-one in-depth interviews. So after the recruitment, I had a total of 11 participants, and here are the demographics. So just really short, what I want to say is that I had a larger representation of Nigerian women, Alabama representation as well, and the residency spanned really large between 1 to 22 years. And I had a really highly educated population of mainly graduate level, but college level African immigrant women. So I looked at three things with the findings, but from those three things came so many emergent themes. So I can't get through all of them, but here, feel free to like take a screenshot. But I looked at mental health definition, just kind of how they understood mental health. what were those different kind of influences between their home culture, the U.S. culture, and motherhood transition, and how important did they see their mental health. So something I'll say about the mental health influence is that many things influence their perception of mental health from back in their home country with some of the perceptions that they're used to. So a lot of it stigma, taboo, non-existent. Their motherhood experience once they go through childbirth or just those natural mood changes. And even in the US, just how we talk about mental health a lot and have more of a comprehensive approach to that. When it came to mental health service utilization, and in this, what I was asking about was like their willingness to seek mental health care. So, specifically talking to a mental health professional, the type of support systems they have. So, who do they go to, and what kind of support do they get from them? And then, what are some of the social cultural support? So, what are some of the things that they do culturally that help them with their well-being? So I'll go up to the willingness to seek mental health care. And what I want to say about that is that there was mixed responses there. For the most part, they seemed that they were open to using a mental health provider if they needed. Some actually were open about sharing their experience, and some did share that they're still holding on to some of their cultural upbringing and beliefs around mental health. They don't feel comfortable, trust privacy. There were a lot of factors that came up as barriers and facilitators to why they wouldn't use a mental health counselor provider. And last but not least was the recommendations for mental health support. So in this was really hearing about like information that they thought would be helpful, other support, whether it was specifically about mental health or the motherhood transition or just outside of that that they felt would be helpful. And then anything else that they wanted to talk about around recommendations. So there's just so much in these, and results are still forthcoming. But I did put a few here, and some that I will highlight is inclusion of partners and families. So if you see on the bottom right here, and I thought that one was really interesting because a lot of them mention that when you want to talk about mental health or you want to talk about African women or African maternal mental health, include the whole family. You know, our partners are really important in this conversation. Our children are really important. We do everything as a family unit. And there was a lot of um, recommendations for caregiver support. That was one of the main things. It wasn't even about mental health. It was about we really just need assistance with watching our kids, financial support, daycare, family members to come over, visa support. So a lot of things around there. Okay, I know I have like just a minute left, so we can talk about this later too, but just some of the implications for practice and policy. So going back to like all three of these papers and thinking about like the so what for us is recognizing that in the US we are a diverse and big community. You know, everyone should feel welcome and supported. And African immigrant women, specifically here in the US, they contribute significantly to the US in multiple ways. When I was talking about the economy, the workforce, even with these women mainly being like educated and students or in the healthcare sector. And there's a lot of silence that goes on too when we talk about like mental health, maternal mental health. We often forget to include the immigrant community, especially African immigrant community. A lot of them felt like they need more cultural tailored resource and support. They need more support with some of their well-being in terms of like visa, immigration, caregiver, parental leave support, especially with them being students and not even having that option and having like that demand to work and be a student was really difficult for them. All right, and I want to thank you all for being here today and listening to my talks. And if you do have any questions or interested in hearing more, feel free to please email me at the email listed here. Thank you.
Thank you, Joyce Lena. I'm going to add the spotlight to Anastasia.
Well, good evening, everyone. My name is Anastasia Smith, and my background is that I've received my MPH in 2012, my DRPH last summer, and I've been working in the pediatric neurosurgery as a clinical research manager for about 14 years. So my dissertation really fitted well with my work environment, which was also how I got inspired and came up with the topic for the dissertation was through working and created an idea through with my team. And then I went into the doctoral program while also working full time at the same time. So they're all very much intertwined, as you'll see. All right. So, but overall, the big topic of my dissertation is really prevention of spina bifida through fortification, specifically of salt with folic acid. I will go through and very briefly try to give you like basic terms like Joyce did, and then go through my paper 1 and 2 really quickly, and then focus on paper 3 mostly because that's my biggest product of my dissertation work. And then I'll try to give you a little tidbits of some of the policy advocacy work that I've been involved in through this work. All right, so what is spina bifida? Very briefly, it's a type of a neural tube defect that happens in the first month of pregnancy before the woman realizes that she's pregnant. It's the closure of the tube that forms your spinal cord. It doesn't close properly. And so when the baby is born, the nerves and the spinal fluid are out and about, and which causes a lot of lifelong disability, requires a lot of surgical, lifelong surgeries, both for the hydrocephalus, which is in the brain, as well as for the spine. These children, later on adults, require orthopedic, urological, rehab, neurosurgery quite a bit. And it is one of the most common birth defects in the US, but worldwide. And my dissertation is both global and the US focused as well. But globally, about over 300,000 pregnancies are affected with neural tube defects, and half of them are either terminated or are stillbirths. So I mentioned I work in neurosurgery. So my paper 1 was focusing on some of the neurosurgery resources that are needed to treat patients with spina bifida. And so globally, about every year, 13 million people require neurosurgery in general, not just for spina bifida. But we also know that there's a huge deficit of neurosurgeons. There are some countries that have 1 neurosurgeon, and there's some countries have none. US has, of course, higher income countries have enough. So most of the countries that are missing the resources they need is the low middle income countries. The data that's currently known is that there's about 45,000 of babies that are born that are live births with spina bifida that require care. However, we have no data. We don't have any data on how much of actual time the neurosurgeons spend treating these patients over the course of their lives. And I'll get to a point why that's important. As I mentioned, these patients, most of them end up living into adulthood if they survive the birth. So gap here in the literature was that there was no evidence or no data available on how much clinical time the neurosurgeons spend on treating the spina bifida patients. All right, the risk factors. The most prevalent risk factor is epigenetic factor of maternal folate, meaning if the woman does not have sufficient levels of folate in her system at the time of conception, the fetus is at a high risk of developing a neural tube defect. I'll leave it at that. There's a difference between folate and folic acid. Just so you understand, folate is a naturally occurring vitamin. It's found in leafy greens, however, extremely difficult to consume enough of your leafy greens and Brussels sprouts to have a protective effect, which is where folic acid comes in. It's a synthetic form, and it's found in your vitamins, multivitamins, prenatal vitamins, but more importantly, it's very easily can be fortified into various foods. And we'll talk about that. And actually, I will mention that fortification of food with folic acid it has been one of the best public health interventions from the prevention standpoint. And that's what US did in 1998. They fortified wheat flour products with folic acid. So anytime you eat bread, croissant, eat pasta or cereal, you're getting folic acid in. And the US rates have dropped by about 35%. In some other countries, those rates dropped by 70%. So it just depends on your baseline. At the moment, to this day, still the Hispanic population has higher rate of neural tube defect and spina bifida, and that's something that we are working towards. Very important to note that half of the US women consume folic acid through fortified foods. That's huge, again, public health intervention. It's very cost saving. So there's a lot of data that shows that fortification is effective just on a cross-sectional, and Haynes does these, puts out these reports every few years that shows, look, fortification is working, we've got, our rates are down. But there's been no data, and I was really curious to show how it is on an individual level. So meaning the same person before 1998, I wanted to look at their blood folate, and then I wanted to look at it after fortification. And because there are still some skeptics, that say, well, you don't have it on the same individual, so can you show us that? So I wanted to show that, and I did. All right. What is, from the global perspective, what is the current prevention efforts happening in the world? So through the fortification of various foods, and mostly it's wheat flour or rice, we have about a quarter of the cases are prevented globally. Now, if we fortify salt, which you'll get to that in a minute, modeling studies have shown that we could prevent an additional 65%, which would get us to probably maximum of the prevention efforts that we could do. And as I mentioned, the food vehicles currently are wheat flour, maize flour, or rice. However, if you were thinking from the global perspective, as you would know, especially low-income countries, they tend to grow their own wheat, their own rice, maize, and they don't buy it from the store. So even if you did try to fortify it, it's not going to reach majority of your population that really needs it. So that's where the salt idea came into place. We know salt iodization has been extremely successfully globally. We know salt is inexpensive. Nobody makes it. It's always centrally processed, and people consume it. And so we thought that, well, salt would be a good potential vehicle for fortification. And so at the time of my dissertation, there was another study happening in India that was simultaneously, and their results were very positive. However, India does not have any sort of fortification policy like US does. So what I wanted to do is a complement to the India study. I wanted to show that even in the US, we still have room for improvement, and salt could be a nice complementary fortification vehicle. All right, paper one. Paper one was a survey of neurosurgeons globally, and I wanted to evaluate the awareness regarding the clinical time, how much time they spend on these patients, the prevalence of spina bifida in their countries, as well as the awareness of the prevention strategies that are happening in their countries. It was a red cap survey that I sent out through various neurosurgical organizations. And I had about 234 respond, which is about 70% response rate from 65 countries that are highlighted blue on the map. So it was a good response rate. I was quite happy with that. So the key results were that the prevalence rate of spina bifida was the highest in the low-income countries, as expected. What was not expected is that about a quarter of all neurosurgeons, regardless of which country they were from, about a quarter didn't know what their local rate of spina bifida was, which is very surprising, considering that they treat these patients. And another very key result, we found out that neurosurgeons from the low-income countries were spending 6 times, were 6 times more likely to spend about 1 day of their clinical time treating these patients. And think about it, 1 day a week on these patients, where in countries that have 1 neurosurgeon for entire country. Their clinical time is so invaluable that we have to do something about that. When we asked them about what's their current prevention strategies, the multivitamins or supplementation pills was the highest reported strategy, followed by flour fortification. The high-income countries reported termination which is Europe mostly. That's their strategy, which I wouldn't call it a strategy, but that's what they do. And then the low-income countries have no prevention at all. It is very important to note here that supplementation pills is ineffective public health strategy for prevention, because we know as public health professionals, half of the pregnancies at minimum are unplanned. If you don't plan for it, you don't take your pill until you know you're pregnant, and by then it's too late. When we asked neurosurgeons from their perspective, what would have been the most practical method of prevention, they said flour fortification followed by salt and rice. So great pathway. And they also mentioned that, of course, lack of political will and awareness among the politicians was one of the main barriers to implementing fortification in their country. So main conclusions from this was that this was a very unique set of information from a specialized field of medicine, but it gave us a nice insight on what's happening from the long-term care of these patients globally. We, again, the LMIC neurosurgeons spend a lot more time than the HSC counterparts. And then also there's need for awareness and education. And we do believe still that neurosurgeons could be nice advocates for prevention. So in my second paper, I wanted to show that direct increase in the folate after fortification in the same individual. So I wanted to quantify that change in the folate. And I also wanted to assess the insufficiency folate. So there's such a thing as deficiency and insufficiency. Deficiency means your folate levels are very, very low. It's extremely dangerous for you as a human being. However, insufficiency means your levels are kind of in the middle, but they're not sufficient enough to give the protective effect to the fetus. And that's why US doesn't have deficiency, but the data have shown that we're about 20% insufficient in the US. So I wanted to see that specifically in Alabama, in this pairwise comparison. And so what I did a secondary analysis of a cardiac cohort participants, which is a 40-year-long prospective study. They have about 4 centers in the US. They're in year 4, where they follow the same group of men and women, Black, white, and men and women. But they happened to draw blood on them before the fortification in 93 and then post in 2000. So I had a perfect set of blood for the same participant before and after that could show me that direct link. Very briefly, I ended up having 1,400 people in my primary outcome analysis, which was a pairwise change of serum folate from before to after. And then when I looked at women only, which was about 860 women, where I wanted to look at their insufficiency state after the fortification. So main result, the folate levels doubled from in the post-fortification state, and 90% of participants had a positive change. When we look at the insufficiency, about 60% improved their folate levels to become sufficient. However, 38 still were insufficient even in the post-fortification era. So now what I mentioned earlier is that the most recent enhanced data from about 2016-ish said that we're at 20%. So we still have room for improvement. We're getting better, but we still have room. Very briefly, conclusions. This showed that a direct evidence of high effectiveness of fortification on the same person, changing their blood levels, which was great. We still have room for improvement, especially in the Black and Hispanic women. And there could be a potential additional solutions to the insufficiency problem if we try other staple vehicles, such as salt, which leads me into my third paper, which is the study that I was really excited most. This was a clinical trial that I conducted here in Alabama and in Birmingham, actually, where we wanted to assess the change of the serum folate concentrations after 1 month of consumption of salt that had folic acid in it. We wanted to also assess the feasibility of this salt and acceptability of it by the population. And this was funded by Lister Hill, our own. So this was a non-randomized intervention trial, just one cohort, 1 month follow-up. My target was about 30 women, and some of you may have seen these flyers on campus. This was about a couple years ago. But more importantly, I really needed the women to either live alone or be with a partner, but not share the salt, because I needed to measure how much salt they've actually consumed for the quantification purposes. The salt has a yellow tint because folic acid, because of the folic acid, which is also why I was measuring the acceptability of the salt. But it had about 100 micrograms of folic acid per 1 gram of salt. We were estimating that about 2 grams of salt were going to be consumed by the participants for a total of 200 micrograms. To put this into perspective, your multivitamin has 400 micrograms. So we were about half of the recommended dose by the WHO and CDC. But the participants were asked to only use the salt for 1 month. So they would cook with it. They would take it with them to the restaurant. They were extremely great participants. They were wonderful. And they actually did it per the protocol. And at each visit, they had a blood draw, a whole lot of surveys, thank you, and they filled out a daily log if they used the salt or not, because I needed to count how many days as well as weigh the salt shakers. I'm not going to go through the analyses, but basically I did a paired sample t-test and Wilcoxon-Signrain test for the paired samples to do the comparison of their blood pre-salt, post-salt. So I had 32 women who've consented and completed the study. However, 3 of them had really, really high folate levels at baseline and post, which was a huge outlier. And per some of the analysis in other CDC paper, we excluded them just because it's not the norm. So all of my results are based on the 29 women. Briefly, they're all average ages of about 26. I had equal number of white, black, Hispanic, well educated. No one had a history of NTD, and about a third were taking vitamins. So I measured that. 28 out of the 29 participants increased their folate levels after 1 month, which was statistically significant. So again, it shows we can improve our current state of folate. And we saw that increase across all race and ethnicities. And what I did find is about 47% of my women, so about half of them, were still insufficient in their folate levels, which is double what the latest national reporting is. So that will come later in a minute. Regarding the feasibility acceptability, everyone who's consented completed the study. The overall consumption was less than 2 grams, however, about 24 days of consumption. And from the acceptability standpoint, more than 90% said the salt didn't affect the taste of their food, and the color, the yellowish color of the salt, did not affect their desire to use it. So they said it was absolutely fine, which was great. I'll skip that real quick. All right, implications. This study was a pilot study. It's novel. It was never done in the US before. It showed a meaningful, even though small, increase in serum. It was feasible. It was very acceptable. And so it's paved the way for potentially global fortification. So my next steps is that I'm starting clinical trial in Zambia in the fall. Cross my fingers. And the reason we picked Zambia is because we have a good infrastructure there thanks to UAB, but also they don't have a current fortification policy. So we expect to see an increase in folate probably three times. I also would like to do screen the blood folate levels in Alabama, specifically for Black and Hispanic women. I mentioned we have about, in my sample, I had a half of them were insufficient. So really want to make sure that that's still true for Alabama. And we do believe that it's possible that the insufficiency is low because Hispanic population, they prefer corn masa products, which are not fortified like wheat flour. So anytime you do tortilla or chips, they don't have folic acid in them. So that population is at a higher risk. And we also anecdotally noticing higher rise of gluten-free diet, which if you're eating gluten-free food, they're not fortified. So that's another avenue of my next steps of work. Real quick, do I have a little bit more time? Can I have like 2 minutes?
Sure.
um, okay, so policy and advocacy. I got really lucky that I am part of an amazing team in neurosurgery who are a powerhouse. And one of my neurosurgeons, Dr. Blount, he's the man right here with the beard. Um, so we he co-founded an organization called Global Alliance for Prevention of Spina Bifida. And it's really started out with just neurosurgeons, but now it's grown so much to include public health professionals, NGOs, um, other physicians and the sole mission is to help implement fortification in other countries. So if somebody wants to come in and say, hey, I'm a pediatrician and I see a lot of children with spina bifida, we've got to do something about this. We kind of help them work through the process of, okay, here's the data, here's the steps on how to implement fortification. You have to meet with the industry, you have to meet with the Ministry of Health, you have to meet with agriculture, and depending on what works for that country, we kind of help them put the implementation in place. But before we did that, we wanted to have an official document from the WHO, because it's so highly respected in the world, that said, look, fortification is important. You guys really should do it, and urge the countries, member states, to do it. So in 2022, we went to the WHO Assembly, which is their big meeting where they make decisions about resolutions, laws, things that they're going to happen and they're going to enforce. And we put together a side event, and side event is very important. So not everybody can go into the assembly. Only people, with the Ministry of Health can go in there. So side events is actually where all the business happens and all the decisions are made, which are the events outside of the assembly. So we put an event where we put together a draft of the resolution, and we, as a civil society, cannot bring it to the WHO. It has to come from a country. So country of Colombia was very interested and liked our resolution, and they sponsored it, along later on with about 22 other countries. But then this, side event we put together, and they spoke in its support. The Minister of Health, this beautiful lady up here from Ethiopia, said that this is very important. And 2 years later, she actually passed the law in Ethiopia that says you have to fortify, and now they're actually doing flower fortification. So this was the start of all this big implementation work that we've been doing. In 2023, after about a year of discussions and working on the resolution draft, we put another side event, and during that assembly, it was adopted. So there's now official resolution that urges countries to fortify their food. And every resolution has a 3-year reporting period. So in 2024, we kind of took a year off. We went back this year, which is a year 2, and we put another event where we presented about 6 countries came in and reported on the fortification status. So since the resolution went into effect, where are they at 2 years later? And it was important because other countries listened to it, and our hope is that they would want to do something about it by next year. So next year is a big reporting year, and that's when all countries have to submit a report on what they've done so far. So we're trying to help them implement it so they can positively report on something. And at the event, we also had a panel that I got to speak about the research that goes into it. So I got to talk about the salt fortification, which was really cool from my standpoint. All right, and then was my last slide, I promise. So I mentioned to you that corn masa fortification is not, or corn masa is not fortified. It was excluded from the mandate in '98. And we see a lot of Hispanic babies. So we put together a bill in Alabama, and Representative Danny Crawford was wonderful. He helped us, and he sponsored the bill, and he brought it to the floor. The House passed it in March, and then Senator Melson took it to the Senate, and the Senate passed it, and on June 9th, Governor Ivey signed the bill that says that in Alabama, starting in June of 2026, if you are going to sell any sort of corn masa products like tortillas and corn chips, they have to have folic acid in it. Otherwise, they're not allowed to be sold in the state. So we're hoping that that will help our Hispanic as well as gluten-free communities to get the same effect that everybody else does in the country who eat the wheat flour. And today we got acceptance by the Pediatrics Journal about this work. All right, that's it. Sorry if I went over. I'm sorry.
Not a problem at all, Anastasia. Thank you. I'm going to take the spotlight off of you right now, and I'm going to add it to Aduke. And Aduke, you can be our final presenter, and then when you're finished, I'll come back on and try to facilitate a bit of a Q&A.
Good evening, and thank you for this opportunity to share my research. My background, my name is Aduketu Luhi, sorry, I didn't give my name. And my background is in medicine and public health. This presentation is based on the qualitative aim of my dissertation, which examined the maternity care experiences of non-Hispanic Black women with cardiac complications in the US South. I have no conflicts or disclosures. My pre-doc fellowship was funded by the American Heart Association. I'm currently the principal investigator for an American Heart Association funded PEACH study. The PEACH study is the pre-pregnancy and interpregnancy engagement for Alabama's cardiovascular health literacy. So as a background to my presentation, despite numerous researches and interventions, maternal mortality rates remain high and racial disparities in pregnancy outcomes persist in the US. While the maternal mortality ratio fell in 2022, they rose again in 2023, with the maternal mortality rate being highest among non-Hispanic Black women, which is, and you can see the rates there, and this is about 3.5 times the rate of non-Hispanic white women, and the non-Hispanic Black, non-Hispanic white racial disparity is actually attributable to 4 cardiac complications, with including things like preeclampsia, eclampsia, postpartum cardiomyopathy, obstetric embolism, and obstetric hemorrhage. So in Alabama currently has the third highest maternal mortality rate in the whole of the United States. And I'm not sure why. Okay, that's not it. Historically, not just in Alabama, maternal deaths have been higher in the US South compared to the Northeast, as you will see in this map. And research shows that experiences of racism and discrimination contribute significantly to the persistent racial disparities in maternal health outcomes in the US. A CDC survey conducted in 2023 revealed that 20% of respondents reported mistreatment while receiving maternity care. 29% of all respondents reported discrimination, while approximately 40% of Black, Hispanic, and multiracial respondents reported experiencing discrimination while receiving maternity care. Research shows that maternity care experiences influence pregnancy outcome. Studies indicate that non-Hispanic Black women often feel powerless to make decisions and have a sense of loss of autonomy and self-determination during labor and delivery in hospital settings. Therefore, they are unable to take an active role in their care and are not included in decision making. So generally, Black women are more likely to be disrespected. They have stressful interactions with all levels of maternity care providers, and they have unmet information needs relating to procedures, clinical tests, and rationale for clinical activities for maternity care staff when receiving maternity care. Studies suggest that there is a connection between pregnancy complications and experiences of racism or discrimination, and that mistreatment and discrimination in maternity care impacts experiences of care. The CDC study I referred to concluded that women who feel safe, supported, and respected are more likely to have a positive pregnancy experience. So the aim, the my qualitative aim was to explore the maternity care experiences of non-Hispanic Black women and family members during maternity care in selected U.S. maternity care settings, including Alabama, Georgia, and North Carolina. The study was undergirded by the WHO Quality of Care Framework for maternal and newborn care. The framework basically consists of 8 domains, and when these domains are adopted by health facilities, the likelihood that the desired individual and facility outcomes will be achieved is greater, is increased. So the framework provides a structure for quality of care dimensions, and it shows that quality of care improvements are two linked dimensions, which is basically provision of care and experience of care. And so the framework emphasizes that both the quality of care provided as well as the quality of care experienced by women, newborns, and their family should be given due consideration because they both contribute significantly to the health outcomes. So to get my data, I leveraged on an ongoing study at the School of Medicine, the Department of Obstetrics and Gynecology. The study is called POPI, that is, and it's a study that is examining the use of community health worker and digital health interventions to address racial disparities in maternity outcomes. And we were examining non-Hispanic Black women. So we enrolled 10 non-Hispanic Black pregnant women who were either currently pregnant or who were less than 6 weeks postpartum. They were older than 18 years and had experienced cardiac complications in pregnancy, including chronic hypertension, gestational hypertension, preeclampsia, eclampsia, with or without severe features. We also interviewed 10 family members of deceased non-Hispanic Black women or infants who had received maternity or infant care in one of the selected U.S. southern states. We adopted an a priori sampling approach for the qualitative interviews, and what that meant is that prior to the data collection, we already had established the sample characteristics and structures which we felt would answer the research problem and the purpose for the study. What we did was to amend the qualitative guides, which we used for the overall study for my dissertation for what I was examining. And for the coding, we collected the data through qualitative interviews. Audio recordings of the interviews were uploaded to a secure UAB drive, and the coding framework and transcripts were uploaded to the in vivo software. And we used the WHO Quality of Care framework to identify our major themes and adopted a mixed deductive and inductive approach to analyze our data, allowing the data to speak for itself. And we also conducted a codebook thematic analysis to inform the narrative, and a framework matrix was created for within and across case comparison of the themes. So this is just a schematic of the coding framework. And so this is the experience of care framework. And under the experience of care, we had these sub-themes, and then we had second level sub-themes. And we further expanded these to highlight key factors affecting the quality of maternity care and experiences for non-Hispanic Black women. So these are some of the participants' characteristics. For the non-Hispanic Black women, they had, like I said, they had pregnancy-related cardiac complications. And these are the characteristics of the family members who were either mothers of deceased non-Hispanic Black women or non-Hispanic Black women who had experienced an adverse outcome in pregnancy. So for the results, we found out that the communication gaps with maternity care workers, lack of information, and poor coordination of care persisted, and effective communication, respectful maternity care, and emotional support were identified as highly valuable factors in experience of maternity care, and participants highlighted their preferred manner of treatment by maternity care staff, emphasizing their desires to be treated with dignity and equity. So I'm going to show you some of the results, some of the quotes from the participants to highlight the key findings. So here, the first quote, we see someone who had a very positive experience saying that everything she needed to know, they were sitting her down and telling her. And then conversely, another person is saying they never told her anything. She never knew what was happening. And so we found very mixed perceptions. While some felt they had adequate information, some felt they were really kept in the dark. They didn't know what was going on and they would have really loved to know. Um, and other people felt the coordination of their care and the lack of continuity contributed to the outcome of their pregnancy, saying that every time they came to the hospital, they saw a different prenatal team. They saw different people. Some people said they didn't see their doctor until they went into labor and things like that. So and they felt this affected the quality and the experience of their care. In terms of being treated with respect, while some felt they were treated with respect, they felt they were treated fairly, everyone was doing a good job and all that, they were very attentive to them. Others felt that they were treated very rudely. Some did it, the second quote shows the experience of a woman saying she was in pain, she was post CS. She didn't want to call for help because every time she reached out to the help desk, they were very rude to her every single time. And so she preferred to stay in pain until a nurse or somebody came into the room. In terms of perceptions about the support they were receiving, some felt they were very well supported by their practitioner, their healthcare provider, while others felt they were not supported. The doctors, the healthcare providers were not supportive at all. They felt they could have been given more information. They felt they could have been more supported, and some even linked it to the source of the type of health insurance they had, feeling that because they were on government health insurance, they were not giving the level of support they felt they should have been given. We also looked at how the quality of care influenced pregnancy outcomes. And you'll see in this quote, this woman called 911 to get an ambulance because she felt her baby was in distress. And the ambulance stopped on the way at the gas station to get gas, to put gas in the car. And by the time they got to the hospital, there was no longer any heartbeat. She lost the baby, and she had kept on asking the ambulance driver, "Why are we stopping at a gas station when, she's in distress and all that?" And so that she felt the quality, that experience influenced her pregnancy outcome. She lost her baby because they stopped to get gas in the ambulance. Another participant said she would have loved her daughter. This is a family member, a mother who lost her daughter in pregnancy due to cardiac complications. She said her daughter was not respected. Her daughter has a dual PhD, including epidemiology, and yet she was not respected. She wasn't treated well, and she wasn't given the level of care she should have been given. If she was, she felt her daughter would have been alive, and all she would really want is for healthcare practitioners to treat her daughter and other non-Hispanic Black women as they would treat their family members. So in summary, there are mixed perceptions about maternity care experiences, racism, and the influences of these on pregnancy outcomes. But what we did find is that highly valued factors in experiences of maternity care include effective communication, respectful maternity care, and emotional support. And the implications of this is that maternity care experiences of non-Hispanic Black women may negatively influence pregnancy outcomes. And it is important. Our findings underscore the need for the inclusion of experience of care, performance measures in quality improvement initiatives for maternity care. So efforts to improve the experience of care during maternity services are urgently needed to reduce racial disparities in maternal health outcomes and improve experiences of maternity care for all women, especially non-Hispanic Black women. So thank you. That's the end of my presentation. I know, very short and sharp.
No, it was perfect, Aduki, and all three of
Yeah.
you done a great job in keeping us on time so that we can have a nice Q&A session. The chat box is available for those of you that don't want to unmute and ask a question. Um, we also had 3 questions submitted as a part of the registration process. 2 that I've already shared with the speakers, but I'll share them again now just so that you all have a reminder. One was, is there any research going on in India that UAB is a part of? And the second question was, are there any opportunities to join you in your research? Um, but a third question came in right before the seminar started, and that was, what would you tell someone going into this field as they stare down the current political climate? So I think I'm going to get us started with those 3 questions, and any one of you can chime in. I've got you all on video, and we'll just take it from there.
Okay, in terms of research in India, I'm not aware of any. I do know, I believe there was something the School of Public Health was doing in Pakistan with the Aga Khan Institution at some point, but I've been away from the School of Public Health now for almost 2 years. So I guess those, maybe Joyce, you know something about that?
I'll have to think. There may be some professors that are doing some work, if not India, maybe close by.
Hmm.
Um, But yeah, and to also answer the question in terms of like if there's any work to do, like if someone wanted to support, fortunately at this time for my research, there's no opportunities right now, but I do want to shout out Nia who's here. And I did reach out to MCHSA, and I usually do when I'm doing research or I need like support or volunteer for something. So you all are definitely some of the first members I think of. So thank you, Nia, too, for helping with the coding.
Okay.
She did a great job. Yeah.
Okay, so with my current research, which I briefly talked about at the beginning, it's pre-pregnancy and inter-pregnancy engagement for Alabama's cardiovascular health literacy. We are beta testing cardiovascular health literacy intervention into maternity care deserts in Alabama, in Marengo and Chambers County, and we are about to roll out the intervention from the 23rd of August. So if you would like to volunteer, I do not have any extra funding at this point to pay anyone, but if you'd like to learn more about the research and about about the intervention, please feel free to reach out to me.
I think there's a question in the chat for me regarding the Zambia connection with UAB. So I'll put this link in here, but I'm assuming most of you are familiar with the Sparkman Center. And so you can become a Sparkman Fellow. And anyway, that's just a fact. So for those who are looking for like India or Zambia connection potentially, you can become a Sparkman Fellow and they will send you to do like your internship or something else at another site. But from what I understand is that back maybe 20 or 30 years ago, there was a collaborative partnership set up by, I think maybe Dr. Max Michael, maybe even before him, um, in Lusaka. And they set up the CITERS, which is Center for Infection Disease, something control of Zambia, I think, something like that.
Mhm.
But it was an
Mhm.
infection diseases specific. But it created, I haven't been there in person yet, I will go, but I from speaking to the faculty there, it's a very good infrastructure clinical research center. And
Mhm.
Aduki shaking her head sounds like she's got some
Yeah.
more information too. So um I, and some of the faculty are dual faculty, both UEB and the University of Zambia. So that's extent of my knowledge. But I just know it's
Yeah.
a good infrastructure for research. So I was like, great.
Yes, and just to piggyback off of what you said, it is, and I actually just we submitted a paper, myself and the team over there. We did a paper on high volume breastfeeding in what's in breastfeeding mother in low birth weight infants in CEDAS. So just like you said, we have professors, UAB professors there. The person in charge, his name is Dr. Albert Manassian. He's the one I work with. So we've collaborated. You know Albert, yeah.
He's
So
my
he,
Zambian PI.
oh yes, so he's the main UAB person in CEDAS, and he's the one we collaborated with to write the paper. So it's under review, so you can be on the lookout for that. The yeah, Dr. Albert Manassian. He's yeah.
That's great.
And I want to highlight a comment that Joycelyn put in the chat because it pertains to more than just the particular question. So the question was about the work in India, and Joycelyn had said that she would suggest reaching out to the UAB Sparkman Center um, because they would have ideas of professors, not just in the School of Public Health, but across other disciplines who might be working in India. But they would also have information potentially about other countries,
Correct.
working on in other
Mhm.
countries. So wanted to highlight that. Let's see, Aduke and Joycelina, we have your contact information in the chat. Anastasia, did
Yes,
you put it in
I
there
put mine
after
in.
you were done
Yeah.
answering? Okay. So what other questions do we have? Put them in the chat or unmute yourself and ask one of our presenters.
Yeah, and while people are thinking of questions, I give my answer regarding involvement of other students in research. Um, it's not a great answer, but it's an answer. So, as you saw in some of my next steps, I've got some ideas for projects to do here locally. Um, we mainly work in my job with medical students because we generally have them for about 4 years of their medical school. So, graduate students, especially like MPH or master's level, they most of the time will only need like 4 months of an internship, which is unrealistic to do in clinical research. Um, or they could hop on a project, potentially collect some data, but it's not really meaningful. So if you guys are interested in doing something where you can dedicate a year at least, maybe two, then we can consider talking and seeing if we can get you on a project because we have a very large research program in neurosurgery. It's also very diverse. As you can see, two of my neurosurgeons have masters in public health. I have a doctorate. So we are not just we're very surgical, but we're very public health focused too. So there is opportunities, but commitment's got to be more than just 4 months for internship. Answer.
Okay, so
Oh,
the
political
question.
climate.
Take it away, whoever wants to answer that third question or take a stab at it.
Hmm.
I
I
can
mean,
take a
go
go
ahead, Joyce.
go ahead.
Go ahead.
I mean, I was gonna say, I'm sorry, but I mean, I had somebody who had postpartum depression, so the fact that Joyce is doing this work, I mean, please and thank you. So we can't just stop doing our work just
Yeah.
because somebody's in the office for 4 years. So I say keep it going, be mindful about how you phrase things. Maybe
Mhm.
don't be very blunt about it, just cordial. I mean, if you think about it, the corn masa bill, we got passed in a very, very red state. And it's all about how you present it to them. It's all
Mhm.
about you're gonna save all this money. It's not about the Hispanic. It's all about the money. So
Mhm.
you gotta be smart about it. Do your work. Go ahead, Joyce.
Yeah, I agree with that, Anastasia. Just like tagging on, that was something I learned in the program too. Because me, I'm coming from like a community health, like social justice background. So I'm really like someone that's like posting, putting news, like debating. So going back to what she just said about just being strategic about how we present stuff, when there is difficulties like this is definitely the time to go into any kind of social justice oriented field, whether it's research, public health education, like this is actually the perfect time. So don't be discouraged, be like motivated, like turn your frustration, your concern, any of those emotions into like your passion and, your power to really make a change. So even doing this work, because I started my interviews in the end of January, and that was like right after we got the new administration. And I was just like, oh goodness, I don't want to do this anymore. And I have, my population of interest is immigrants, and they're not going to want to talk about this topic. And it was tough. It was honestly tough, like getting enough participants finding it. It took time. So even though Duque helped me, so many people helped me. Julie, everyone, like I'm just like sending my announcement out. Um, but as much as I also thought, okay, I don't want to do this anymore, the back of my mind was like, this is what I signed up for, right? If you're in public health, if you're in any of this is the time when you're really needed. So like, don't quit your jobs. That's usually my advice. Don't leave the position, stay in there and fight. But I also understand like trying to balance out your own wellness too, because you go through it. So as I was talking to these women, I'm asking like, what's your support system? I'm actually taking notes and learning like, hey, I need to exercise more, go out on walks, have my self-care to make sure that we're okay too, right? So I would say just be like really strategic, still stay in it, get a good support system, not just self-care, but people around you that are doing the things that you want to do, that what is gonna really help make the difference. And we can talk about that more, whoever wants to just email me. I'm always happy to hop on a Zoom call and vent.
There's a question in the chat I'd like to quickly address.
Yes, but
The
before that,
Oh yeah.
I wonder, Anna, did you put your video on for a reason?
I just had a question
Yeah,
too, but
go
we
for
can
it.
answer the other one first.
No, go for it.
Go
Go
ahead, go
for it.
ahead.
We'll read the chat in a minute.
Thank you. I was just gonna, it's a simple question, but I was just gonna ask, what was your first step into maternal child research? Like how did you get started?
Is that question for all of us, right? We're all
Yes.
kind of
I'm
in.
so sorry for all of y'all. Yes.
Okay.
I think I first got started, and I'll be quick. So I first started in education. I know I was talking about community health, but way back when I was like in education, working with children on the autism spectrum. So I got into more education and health, mental health through that lens. And then psych was my bachelor's, and I really got interested in like the counseling, mental health, wellness promotion from there. And like I said, when I started this program, I was really interested. I still am on maternal mortality, so I really liked hearing Aduke's presentation, and Anastasia's as well. But I was really, really excited about that. And then from there, that link into back to maternal mental health. So it's kind of like a full circle.
Mhm.
For me, my background is in medicine, and I got my degree in sub-Saharan Africa in Nigeria. And so, really, I went, being in that system, I was frustrated with the fragmented health system, incessant healthcare worker strikes, and, the system was just broken. Not to say that the US has its own challenges, health, but it was just like that. And I found out that most of the people who suffered were the women and the children, and the poverty level in the country and things like that. But then, so in Nigeria, we have something, it's almost like your Peace Corps. We have a 1 year mandatory National Youth Service Corps. It's like a paramilitary thing, and it's mandatory. So you have to do that for 1 year, and they send you anywhere in the country. So they sent me to a state I'd never been to. And, I went there and I found out that, they weren't coming. So what we did was we started organizing mobile health clinics and going into the communities rather than waiting for them to come to us in the clinic. And, just doing that, I was just like, if I didn't feel fulfilled, I'm sitting in the clinic, nobody's come, the people who need it aren't coming. They're dying in the communities. So, and then from there, I started working with developments on organizations, USG funded programs like USAID. USAID. Just to put it out there, USAID did very good work in Nigeria, so and in Africa. But yes, we worked with USAID funded projects and things like that, and we did a lot of work. And so, that just motivated me, maternal and child health, PMTCT, nutrition, polio, and things like that. So that's how I got into maternal and child health, public health.
Mhm.
Mm.
Mine is I always wanted to be a pediatrician because I liked children. However, due to some visa issues, I was pre-med in undergrad. So my visa issues, I had to pivot from the med school to a graduate school. And at that time, they had a department of maternal child health. And so I thought that was perfect for me. So I did my master's in that. And then I purposefully wanted to get a job working with children. And so they had an internship in the pediatric neurosurgery. Never thought I would work in a surgical field, but it was wonderful. And I never left. So I just always wanted to work with kids or something to do with kids.
Thank you guys.
And even
Mhm.
though we no longer have a Department of Maternal and
Yeah.
Child Health, that department merged with another department, and we are currently health policy and organization, but there's a maternal and child health concentration for both the MPH and the DRPH. And we were recently funded with a 5-year maternal and child health training grant, which we had for many years in the past, but the last 5 years we did not have it, and we have it now. So although our website hasn't been updated yet to reflect the new information about the training grant, if you have any questions about the training grant, feel free to email me. The last question in our last few minutes was any concern with impact to local Latino Hispanic businesses with folic acid mandate for corn mesa products, or any supports available for those businesses?
It's a very good question. Thank you for asking that. So there is no producers of corn masa products in the state of Alabama. Actually, very few states may have a factory. So all the products are mainly produced in Mexico and maybe a couple other countries, so they're imported. So what this is doing is that this is forcing the producer who's going to ship their product to Alabama that's going to be sold in the store to put folic acid into their product. Otherwise, they won't be able to sell it in the state. So it's not affecting the businesses. The only potential is the cost, but the cost is minuscule. The cost of fortification is 2 cents per ton of the flour. So the consumer won't notice it, and the business won't notice it either. So it's what we're trying to do is California passed similar law. We're passed one, and Georgia's in the works, Florida's in the works, Maryland and Oklahoma. We're hoping that we can have maybe 10, 15 states pass it to where the producers just like, you know what, it's like Maseca and Mission. Mission is actually quite on board with this. But that they're like, you know what, we're just gonna fortify for the whole country and just kind of get that done without a federal mandate. So, but yes. That's a good question. We would not want to harm small businesses at all.
Thank you to our
Bye,
presenters.
everyone.
Thank you. Good
Thank
night.
you.